And what I'd like to do is just take a couple of minutes to go over the background, what's driven better collaboration between mental health and primary care, the current situation, some of the current contextual changes, talk a little bit about the position paper that was produced by the CPA and CFPC last year, and then go over what I think are kind of 7 strategic directions for better collaboration over the next 5 years. 15 years ago, and this really isn't very different from today, we knew the prevalence of mental health problems in primary care is high, often present with comorbid medical problems. Primary care is playing a key role in delivering mental health care. It's a big part of the work of family physicians. But we also knew that although the prevalence is high, the burden is high, detection rates are low, treatment rates were low, individuals often don't receive guideline-based care, referral rates to mental health services remain low, family physicians feel unsupported by mental health services, and there was general dissatisfaction with the relationship. And I think it's fair to say at that time this wasn't seen as an important part of psychiatric practice. So there wasn't always access to assistance when it was needed. But we saw the need for better collaboration between the two sectors. This was the 1997 position paper. At that time, it articulated principles for better collaboration, presented examples of successful models, and outlined some of the potential benefits, because we really didn't know what they were at that time, encouraged implementation, and really looked at ways to improve communication and encourage visits by psychiatrists to family physicians. So fairly modest, I think, in terms of where we are today. And it identified the need for establishing new partnerships. So the original paper was primarily making the case for better collaboration in a fairly uninterested environment. Looking back now, it really focused on individual provider issues. We didn't look at the consumer as a partner. The major issue, I think, was making the case, but we didn't focus on wider systems issues and no real vision of what an integrated system could look like. But at its time, it was groundbreaking. Since then, there have been a number of ongoing developments. The Canadian Psychiatric Association and College of Family Physicians have continued to work closely together. Primary healthcare transition funds in the last decade gave a boost to better collaboration, including the Canadian Collaborative Mental Health Initiative, which really laid a conceptual framework for collaborative mental health care in Canada. The Senate Commission on Mental Health identified better collaboration as a priority in its report, and amongst other things, that's led to CHEER, the Collaborative Healthcare Exchange Evaluation and Research Initiative, a knowledge translation initiative of the Mental Health Commission of Canada. And I think as we move ahead, this is going to be a critically important initiative because it provides an opportunity to take what we know works in better collaboration and translate it, bring it to the attention of frontline providers, look at how it can be integrated and look at how it can be spread. There are recent changes in training guidelines for psychiatry residents and a national conference. This year's national conference is actually going to be held in a couple of weeks in Vancouver. That's the website address if you want to find out any more about it. And don't forget the conference, or you might regret it. Oh crap, was that today? There have been a few other, I think, important and probably more system-wide developments over the last few years. The first is that the Canadian Medical Protective Association have recognised that informal consultation is part of accepted clinical practice. 15 years ago they were saying don't do it. Today they're saying do it, but make sure you do it according to accepted standards of care. There have been changes in provincial fee tariffs to support collaboration. For example, being able to bill for telephone consults in a number of provinces, including Ontario. There are more examples of successful Canadian programs and Canadian data. The CMA and CFPC have embarked upon a broader initiative looking at the relationship between specialists and family physicians, where mental health, I think, is seen as a trailblazer. And even more importantly, consumers are expecting better collaboration. They expect providers to be working together without them getting caught in the middle. So what have we learned so far from successful initiatives? Firstly, we know that there are a number of benefits for individuals. This isn't to say every collaborative intervention has demonstrated these improvements, but better collaboration can lead to a variety of specific improvements for individuals. People like being seen in primary care. It's more accessible, it's more convenient, but it's also less stigmatizing. And when you remember that probably something like 70% of people with mental health and addiction problems receive no care for that problem over the course of a year, but 80% will visit their family physician, it really suggests if we can't bring mental health services into primary care, those individuals will continue to get no treatment. At the service level, better collaboration improves communication. Providers can provide each other with mutual support, often absolutely critical if you're managing cases at the edge of your comfort level or your scope of practice, to have someone who can just say, yes, you're not missing anything, or yes, you're exactly on the right track. Care plans can be coordinated, responsibility for care is shared, and we can solve problems together in ways that we can't do on our own. We can use resources more effectively, we can plan more comprehensively, because often mental health services or primary care services are planned in relative isolation, even though there's a natural affinity between the two. And we can also model effective collaborative behaviours for students. So we've seen an increasing number and variety of successful projects aimed at different populations: children, homeless, seniors, severe and persistent mentally ill, First Nations communities. But we've also seen the same models of collaborative care, shared care, adapted to other contexts. The Canadian Forces, for example, as part of their RX 2000, reorganised the way they deliver mental health services to reinforce the role of the General Duty Medical Officer. Student health services, workplaces, and shelters have all adopted the principles, and I think it's adopting the principles that is critical rather than the models, to try and solve problems they hadn't been able to address properly. The last point, I think, is also a really important one. We know that individuals with mental illness have lower life expectancies, have a higher likelihood of getting a variety of illnesses, and worse care for chronic diseases. But many of those individuals either don't have a family physician or don't have access to medical care when they need it. And again, there are a small but increasing number of models that are looking at how primary care services can be integrated into mental health care settings. And I think that really is another important direction to follow. There are benefits for the system in improving access, eliminating barriers, and by eliminating barriers we can improve communication, increase coordination and continuity of care, and decrease fragmentation of care. Those are all issues that really bedevil any healthcare system. This isn't a panacea, but it does provide some answers and some hope of coming up with slightly different approaches to problems we've been struggling with. And it enhances the experience for the person seeking care. And I think more and more, and I'll come back to this in a moment, one of the drivers of looking at our systems of care and redesigning them has to be how do we improve the quality of care, and central to improving quality of care is improving the experience for the person who is seeking care. We're just starting to look at what that means, how we can understand a person's journey into and through the system as a way of identifying where we could be doing things better. So collaborative mental health care, I think today, is more and more being accepted as an integral part of practice. Doesn't mean every mental health professional provider will get involved in this activity themselves, but I think there's a fairly general recognition of the role that primary care plays and the importance of better collaboration. Planning is now much more likely to be integrated at the provincial or regional health authority level. We're starting to produce more and more Canadian models and evidence. It is increasingly expected by consumers. So I think it is becoming more mainstream, although there may be a few who are harder to convince. But things have evolved over the last 15 years. A number of contextual changes, consumer and family members as partners, emphasis on quality and system redesign. The concept of the medical home fits much more naturally here than it does in the US, where it's addressing different situations. But behavioural health and integrating mental health services is an integral part of any model of the medical home. The expectations of collaboration, but I think as we mature as well, there are increasing expectations of collaborative mental health care programs. We need to be more accountable, we need to focus more on outcomes, and particularly looking at some of the cost benefits of our models in a changing economic climate. Again, part of what we're doing is looking at how we can use resources efficiently. So we revised the paper in last year. We felt we needed a broader system perspective to respond to some of the changes that I've been mentioning, and present a kind of new conceptual framework that really reflected the evolution of the field. If you remember, the original paper was very much focused on individual changes by individual providers. I think this time we look much more at a kind of systems approach. We define 5 levels of collaboration in the paper. The first is just better communication, and if you do nothing else, this will assist in almost every case you see. You don't have to be in primary care to do that. Providing consultation to primary care in an accessible way, whether it be face-to-face or by phone. Coordinating care, making sure different providers are working with the same care plan. Co-location, so you're in the same place, even though you may not be integrated in care. And then better integration of care. And there was a study that came out 3 or 4 years ago that suggested that once you moved beyond 60 feet from each other, the degree of collaboration sort of dropped almost exponentially. So proximity really is an important part of effective collaboration. And as we move forward, I think when we look at the goals of collaborative projects, we can redefine them now in 5 areas. The first is that we want to improve the quality of care provided and the outcomes. The second is we want to increase system capacity by using current resources differently and more efficiently. Not just the capacity of primary care, but the capacity of mental health services as well. Once we can think about an integrated service, then people being seen in primary care with support from mental health services are part of the expanded mental health network. We need to focus on access and reducing wait times. Absolutely central to person and family-centered care, but also it is inexcusable to have the waiting times that we have in mental health services. 6 months for an outpatient appointment, a year for a children's mental health service referral. And this offers one way of doing that. And again, there are trade-offs. There are trade-offs between seeing the maximum number of people as quickly as possible and maybe not being able to give as intense treatment to each individual as we might like otherwise. And I think each program needs to balance that, but not just dismiss one or the other. The fourth is to enhance the experience for the person seeking and receiving care. And I think the fifth, which we tend not to think about, but where there's a lot of evidence that collaboration plays an important role, is to enhance the experience for people who are delivering care. It's less stressful, it's more satisfying, it's more enjoyable. And we've had a number of people in our program in Hamilton, which is integrating mental health counsellors and psychiatrists into the offices of family physicians now for 18 years. A number of family physicians who say, this is just an area of practice which they find more enjoyable, more satisfying, and they're more likely to explore mental health issues in their office. So these are the 7 strategic directions I'd just like to spend the last 5 or 10 minutes focusing on. And I'm going to go through each one in turn. The first, I think, is to define and support the role of primary care in delivering mental health and addiction services. What is the role of primary care? Partly, what can primary care deliver that the rest of the mental health system can't? What kind of supports do mental health services need to provide? And how do they fit together in a vision of a single integrated system? So starting with the vision, I think a mental health and addiction system needs to be grounded in primary care. It's the foundation, it's the first point of contact, and often most mental health care can be delivered in primary care with appropriate support. It needs to be well supported, very differently supported from the way we currently support primary care services. Collaboration, collaborative partnership, they're not an end, they're a means to an end. And collaboration can help link the partners to get better outcomes, which means changes in roles for mental health providers, primary care, and system changes to support both. This is the potential role of primary care, which has an enduring relationship with the individual and their family. There are a number of things that primary care can do that the rest of the mental health care system just isn't in a position to do, particularly if we want to shift to a population-based approach. The picture is of a toddler because I think one of the most underestimated areas of intervention once we start to work together is something like the enhanced 18-month well baby visit. Many, many opportunities to prevent mental health problems early through links with primary care that we can't do until those individuals reach our service. 50% of mental health problems have developed before the age of 14. So, absolutely critical. You know, there's a quote by W.H. Jordan, "In my beginning is in my end." And I think we really need to look at how we can use better collaboration to make sure that no kid gets left behind. So there are a number of other roles of primary care. It should be the point of entry into an integrated mental health and addiction system and able to provide more effective care. But to do that, mental health services also need to change their roles. We need to be able to provide rapid access to consultation and advice. And rapid access means same day when needed, particularly but not only for people who are in crisis and use the phone. We need to respond for help with urgent problems, not emergencies, but again, we need to be able to respond much faster than we do. We need to prioritise those people who can't be managed within primary care and provide care on an ongoing basis as required. So there'll be some people, it's much more of a triage function, but once we stabilise problems, we can return them to primary care as long as we can provide continuing support. We did one small study in Hamilton. We found 25% of our people being seen in outpatient clinics could be seen in primary care with appropriate support. We found 25% of people who were being seen in the mental health program in primary care would have been referred to outpatient services if that support hadn't been available. So this continuity, I think, is part of the continuing collaborative partnership. The second is building the capacity of primary care, you know, what we've started to refer to as primary mental health care. How do we increase the range of services in primary care? How do we increase both the number of people who can be seen, but also the skills of providers in primary care? And how can we use all resources differently and more efficiently? We need to prepare providers to work in these models. It doesn't just happen. People who want to work collaboratively in collaborative partnerships need some preparation or training. There are discrete skills that we can teach. For example, motivational interviewing is something that is easy to teach, easy to adapt to any problem. And there are a whole series of other things that we can assist primary care providers to just kind of have in their back pocket they can pull out when they need them. We need to define the competencies. What are the expectations of mental health providers going into primary care? Support self-management, share and spread what works. And again, I think use of the phone, it's really an underutilized tool of better collaboration. So I think the third is to focus on quality as a driver of change. These are the Health Quality Ontario attributes of a high-quality system. These are the things that we need to use to evaluate our services. Are they safe? Are they timely? Are they equitable? And use those as the drivers of bringing about the changes that we need to see, both within and between our systems. Particularly, I think, understanding the experience of a person who is using the services, which is not just understanding their journey, it's reducing stigma amongst healthcare providers that prevent people from getting the services they need, people being involved as partners in their care, and supporting self-management. Again, a way of increasing system capacity as well as increasing the sense of self-efficacy of individuals, that they can actually deal with their mental health and addiction problems better, with the goal of achieving IHI's triple aim. This is what I think we're looking at with all collaborative initiatives, but trying to do all three of those things at the same time. The fourth is to demonstrate the relevance of better collaboration to challenges facing the healthcare system. This, in a way, is the political or the policy dimension. We have to be able to show that we can make a difference to issues that health systems have struggled with, often unsuccessfully. How can we improve access and transitions? How can we use collaboration to reduce fragmentation of services, improve communication, and increase service efficiencies, moving towards person-centered care? Again, these are all issues that our healthcare systems are looking at, and that collaboration has opportunities to demonstrate answers to. The fifth are system changes to support better collaboration. These are just some of the things that need to be in place. We've looked at things that can happen within clinical settings, but now we also need to look at the supports that are required to make those things happen. So it includes changes in remuneration models, it includes funding support for new initiatives, ways to share our expertise. It needs, I think, the kind of integrated vision that we're talking about, that we're moving towards achieving. And it needs cultures of innovation and improvement, and emphasis on wellness and prevention, and the use of proven quality improvement methods. Challenges for regional health authorities and provinces to build links, fund innovative solutions, really just to support collaboration within their jurisdiction, and I think also for academic institutions, whether it be in training or continuing education, the preparation of learners, learning together, but again, broader system support for these kinds of models. The sixth is increasing the skills of future providers. There are new guidelines for psychiatry residents. Every psychiatry resident now has to do 2 months of collaborative care. We need to make sure that those are successful experiences, because it could be disastrous in a way if most programs weren't able to offer this and residents came away thinking this is a waste of time. There are changes to the primary care residency curriculum, introducing principles of collaborative practice in any health professional training program, but finding ways of learners from different programs to actually learn together. So collaboration is modelled all the way through their training. And again, using the consumer experience, using consumers and families as part of the teaching. And I think the last is to develop and disseminate new knowledge. So we've looked at changes within clinical practice, system supports, preparation of future practitioners, and again, and Elliot's going to go into this in a lot more detail, but I think these are some of the key areas that we identified from the work that's been going on in Canada. We absolutely need to start doing better economic analyses. These are going to be expected and demanded so we can demonstrate the economic benefits. We need better outcome measures. Most of our measures so far have been process or descriptions of programs. We need to look at how we can enhance both the consumer and the provider experience, how we can increase the skills, what models are effective, how can we use collaboration to train, teach, support each other in different ways. We need to identify common evaluation tools that we can then test in different settings. We need to know which populations are best served where, and we really need to focus on access transitions at all times. Because I think demonstrating economic benefits and demonstrating the system benefits are going to be critical. And if we can do all that, then I think there's the possibility that we could find new solutions to long-standing problems. There's Atlas. I can't believe I didn't think of this before.